of vulvo-vaginal candidiasis. So this I have taken from British Association of Sexual Health and HIV National Guidelines 2019, and there is a talk update on recurrent vulvovaginal candidiasis. So these are the resources for preparing this particular talk. So we'll start with management of vulvovaginal candidiasis. So important points to remember in recurrent vulvovaginal candidiasis: microscopy is the primary lab investigation for acute vulvovaginal candidiasis. If it is an acute vulvovaginal candidiasis, the investigation of choice will be microscopy. Culture is no longer recommended as a primary lab investigation for acute vulvovaginal candidiasis. Culture is still recommended for recurrent vulvovaginal candidiasis with appropriate species identification and sensitivity testing depending upon clinical indication. So I hope you are getting this particular point. If you have a case of acute acute candidial vulvovaginitis, microscopy will be preferred. If it is a case of recurrent vulvovaginitis due to candida, culture is recommended. Okay, oral azoles continue to avoid in pregnancy or the women who are at risk of pregnancy and while the patient is breastfeeding. So azoles are not recommended during the pregnancy or the breastfeeding. Ketoconazole is not recommended for the treatment of vulvovaginal candidiasis, and non-azole therapies to be reserved for azole resistance and certain non-albicans candida species. This we have seen in the SBAs. Okay, so they have asked this SBA, which we have seen this. Okay. So coming to the acute vulvovaginal candidiasis, first or single isolated presentation of vulvovaginal candidiasis. This is the acute vulvovaginal candidiasis where there is a first or single isolated presentation. Patients typically present with signs and symptoms of acute vulvovaginitis, and candida species can be detected by microscopy and or culture. Okay, recurrent vulvovaginal candidiasis. How many episodes? At least 4 episodes in 12 months, with 2 episodes confirmed by microscopy or culture when the patient is symptomatic, and at least one should be culture. So the patient should have at least 4 episodes of vulvovaginitis due to candida in 1 year, out of which 2 should have be microscopy or culture. A patient should be symptomatic and at least one must be culture. Okay, patients with recurrent vulvovaginitis will have two groups. One is a patient who had a good or complete response to therapy and they were asymptomatic between the episodes, and the other category where the poor or partial response to therapy with persistence of symptoms between the treatments. So in between treatment the patient is still symptomatic, maybe on a lower side. So that is what is the recurrent vulvovaginal candidiasis. Coming to the etiology, candidiasis is a fungal infection. It is a yeast that belongs to the genus Candida. Yeasts are eukaryotypic unicellular microorganisms which have the ability to develop multicellular characteristics by forming pseudohyphae and biofilms. This pseudohyphae is you will get a typical word where you will have the answer as a candidiasis. So remember this pseudohyphae. Okay, vulvovaginal candidiasis is caused by in 80 to 89% cases by the Candida albicans. Okay, so only 10-11% cases you will get 11 to 20% of cases you will have other species, that is Candida glabrata, Candida tropicalis, Candida krusei, and Paracellosis. Okay, and Saccharomyces cerevisiae in the remainder. So these are not very common, but most common is the Candida albicans. So what are the risk factors and pathogenesis? One is the persistence of Candida species as detected by PCR. Although culture is negative in between the attacks, there can be poorly controlled diabetes mellitus. Patient may be immunosuppressed, immunocompromised patient, or there is endogenous and exogenous estrogen. Such conditions as pregnancy, a patient on HRT, possibly of combined oral contraceptive pill, recent up to 3 months before the episodes, if there is a use of antibiotic use which will cause the disturbance in the vaginal flora. There may be new sexual partner, spermicidal gel cream, non-compliance with antifungal therapy, resistant to antifungal therapy, iron deficiency anemia. These are the risk factors. Okay, so if you have some scenario and if you have got these risk factors, you just think of the candidial vaginal vaginalis or recurrent vulvovaginal candidiasis. So risk factors and pathogens will continue. Another important thing which may be asked is a mannose binding lectin deficiency, MBL deficiency. Okay, this particular word may be can be asked in SBA. Mannose binding lectin deficiency is a genetic condition that affects the immune system. Possessing the MBL variant allele B heterozygous genotype that increases the susceptibility of women to recurrent or acute vulvovaginal candidiasis compared to healthy controls. While the risk of recurrent VVC is also increased for women carrying the allele B homozygote genotype. You should just remember mannose binding lectin deficiency is a genetic condition which is associated with VVC, vulvovaginal candidiasis. Okay. What are the clinical features? Vulval itch, non-offensive vaginal discharge, soreness or burning, superficial dyspareunia, and cyclical symptoms. Then what are the clinical signs? Signs may be erythema, fissuring, swelling, edema, vaginal discharge, typically non-offensive and curdy, but may be thin or absent. There may also be satellite lesions and excoriation marks. So this satellite lesion is also one of the things which you get in candidiasis. Okay. Coming to the differential diagnosis, while women may have a dual pathology, many women have other conditions rather than recurrent vulvovaginal candidiasis, such as you need to rule out other skin conditions like eczema, dermatitis, lichen sclerosis, lichen planus, bacterial vaginosis, trichomonas vaginalis infection, or aerobic vaginitis. If primary complaint is purulent non-offensive discharge, think of aerobic vaginitis. Okay. Then cytolytic vaginosis. Consider if microscopy and fungal cultures are negative. Vulvodynia, vestibulodynia. In some women, this has been triggered by vulvovaginal candidiasis. So these conditions may be associated also. Then you can have other vulval pathologies such as VIN, that is vulval intraepithelial neoplasia, and vulval cancer. Okay. Now VIN and vulval cancer, they are important topics from our examination, RCOG examination point of view, both part 1, part 2. They ask vulval lesions. Okay. So we'll cover that when we learn about pathology and gynecological clinical management. Okay. So this slide gives the difference between the bacterial vaginosis and trichomonas vaginalis. What is the difference between the two, or the similarities between the two? What happens in bacterial vaginosis? There is an imbalance in the vaginal flora causing a rise in the pH, which is above 4.5 up to 6. There can be pH. There are fewer lactobacilli and an increase in the anaerobic bacteria that happens in bacterial vaginosis. What happens in trichomonas vaginalis? It is a sexually transmitted infection caused by flagellated protozoa, that is trichomonas vaginalis. Risk factors for bacterial vaginosis are smoking, dosing, then black ethnicity, new sexual partner, concurrent sexually transmitted infection, that is herpes, receptive cunnilingus. So these are the risk factors which are associated with the bacterial vaginosis. While the risk factor for trichomonas vaginalis are older age. Generally the patient's age is more than 24. Then non-white ethnicity, particularly Afro-Caribbean, concurrent chlamydial trachomatis or Neisseria gonorrhea infection. I think this was a SBA. Okay, so you require a very minute reading. Okay, people living with HIV are known to have this trichomonas vaginalis infection. The signs and symptoms in bacterial vaginosis are offensive fishy discharge, which is typically thin, white gray. Up to 50% patient may be asymptomatic, while vaginal discharge is the predominant feature in trichomonas vaginalis. It can be malodorous also. Vulvovaginal itch, dysuria, vulvovaginitis, vulval ulceration, lower abdominal pain, and up to 50% patients may be asymptomatic. Okay. Investigations: pH test using litmus paper can be done, microscopy, and there are diagnostic criteria available such as Amsel's criteria or Hayeson's criteria in cases of bacterial vaginosis. While in trichomonas vaginalis, what we have is a vaginal swab which is taken from the posterior fornix. Remember, the swab is taken from the posterior fornix for the trichomonas vaginalis. So they will ask you lower vagina, upper vagina, this fornix, that. So posterior fornix, then tested for using Then it is tested using, depending on availability, either wet preparation microscopy can be done, or NAT can be performed, or POC, that is point of care test culture, can be performed. Okay. Uh, then first choice would be triple NAT if available, but if not, then send as a separate sample for NAT, TB culture, and TB POC, that is point of care test, depending upon the availability of testing in particular trust. Okay. So these are the things about the investigations. Then coming to the management of bacterial vaginosis, we have seen it is a metronidazole 400 BD for 5 to 7 days is the first drug. Then metronidazole 2 gram stat. Okay. Then intravaginal we have metronidazole gel 0.75% OD for 5 days. Clindamycin cream 2% for 7 days. Alternative will be tinidazole 2 gram oral stat and clindamycin 300 milligram BD for 7 days. While here I have already discussed in trichomonas vaginalis the drug of choice metronidazole 2 gram single dose stat. Then alternative is a metronidazole 400 to 500 milligram BD for 5 to 7 days. Okay, so the here first comes 2 gram stat and then comes 500 400 to 500 milligram BD orally for 5 to 7 days, and alternative is a tinidazole 2 gram stat. So these minor differences also you should remember which drug is to be chosen as an answer. Okay. So other advices will be general skin advice. Okay. So that is the difference between the trichomonas vaginalis and the bacterial vaginosis. Okay. So other associated conditions will be dermatitis, eczema, lichen sclerosis, other infections such as herpes simplex, vulvodynia, aerobic vaginitis, cytolytic vaginitis that we have already seen. Coming to the microscopy, a vaginal swab of the discharge should be taken and gram stain and or phase contrast wet film microscopy is to be performed. Presence of, just a moment, just can you hear me? Can you hear me now?
Yes, sir.
Yes, sir. A high vaginal swab of the discharge should be taken for gram stain and or wet film microscopy. Presence of blastopores, pseudohyphae and neutrophils is indicative of infection caused by Candida species. Presence of blastopores only and neutrophils may reflect infection by Candida glabrata. So if you have a Candida glabrata infection, you will get blastopores and neutrophils. If it is a Candida species, you will get blastopores, pseudohyphae and neutrophils. Okay, so this pseudohyphae is very important. The neutrophils in vaginal secretion suggest an inflammatory response and therefore presence of infection which may or may not be due to Candida seen on microscopy. Absence of neutrophils in presence of Candida is likely to represent colonization. So if you do not have neutrophils but if there is a Candida, then it can be just colonization. Okay. Coming to the culture, acute vulvovaginitis, we have seen that fungal culture is no longer considered a cost-effective addition to microscopy, nor a reliable test on its own for the diagnosis of acute vulvovaginal candidiasis due to its inability to differentiate between the colonization from infection. So colonization is different and infection is different. So that is why culture is not indicated in acute vulvovaginal candidiasis, while recurrent vulvovaginal candidiasis and high vaginal swab of the discharge should be taken for direct plating onto the solid fungal growth medium, that is Sabarod's plate. Remember these particular things, which medium? Sabarod's medium is used and high vaginal swab is taken. Okay. Up to 20% of the women may be colonized with Candida species during their reproductive years, and without clinical features they do not need treatment for vulvovaginal candidiasis. So unless they are symptomatic, we need not treat them. Okay. Coming to the management, general advice for all women with vulvovaginal candidiasis will be avoiding the use of local irritants such as perfumed soaps or wipes, the use of emollient for personal hygiene as a soap substitute, as a moisturizer and a barrier cream. Patient needs to be informed that this does not constitute internal use. Okay. Sex does not need to be avoided from an infection perspective, as vulvovaginal candidiasis is not a STI. So here the sex need not be avoided. Okay, women may wish to avoid sex until symptoms have been improved, particularly if there is a fissuring of the skin. General advice for recurrent vulvovaginal candidiasis. In patients with recurrent vulvovaginal candidiasis, careful review of their daily hygiene routine may identify potential local irritants not perceived as such by the patient, such as washing hair in the bath water or excessive cleaning, weak association which may be worth considering in certain patients. So, wearing incorrectly fitted clothing made from non-absorbable fabric, using intermenstrual or daily panty liners, vaginal douching. So you need to take into account these particular factors. Vulval emollients may give symptomatic relief, as vulval dermatitis, then both primary and secondary is commonly present. Then further investigations. Acute vulvovaginal candidiasis, no additional investigations are routinely recommended unless it is clinically important. Then in recurrent vulvovaginal candidiasis, we need to do the diabetes, rule out diabetes by urinalysis or random blood sugar or HbA1c we have to do. Consider HbA1c test to exclude diabetes mellitus, especially in prepubertal girls and postmenopausal women who rarely have vulvovaginal candidiasis without other risk factors. So, if you have a patient with postmenopausal lady or a prepubertal girl and presenting with a recurrent vulvovaginal candidiasis, you need to rule out the diabetes mellitus. Advise them HbA1c also. Second, iron deficiency anemia, most important, is associated with this vulvovaginal candidiasis. So full blood count or serum ferritin should be advised. Then screening for MBL, that is mannose binding lectin deficiency, can be considered if there are additional clinical indicators such as history of recurrent upper respiratory tract infections or otitis media or autoimmune conditions, etc. Okay. So vaginal pH testing, if possible, to assess the likelihood of symptoms being caused by vulvovaginal candidiasis where the pH is less than 4.5. Bacterial vaginosis or trichomonas vaginalis will have a pH of more than 4.5. Secretion should be collected from the lateral sides of the vaginal walls using a swab. A tiny amount of discharge is put onto the litmus paper to check for the vaginal pH. Okay. So what is the treatment for vulvovaginal candidiasis? So treatment is different for acute vulvovaginal candidiasis and recurrent vulvovaginal candidiasis. So this treatment is most commonly asked in the final examination. So please remember the treatment. So in acute vulvovaginal candidiasis, you have oral treatment also and you have topical treatment also. The oral is a single dose fluconazole 150 milligram oral dose. Okay. Or topically what you can give is a clotrimazole 500 milligram per vagina single dose. Okay. Provided it is a sensitive to the candida, it is a candida albicans species. Okay, so fluconazole 150 milligram single dose. If it is a recurrent vulvovaginal candidiasis, then you have to treat it for 6 months and you have two phases. One is an induction phase and second is a maintenance phase. In oral, you will give fluconazole 150 milligram every 72 hours for 3 doses, which is followed by 150 milligram orally once a week for 6 months. Okay, so this is the oral treatment for recurrent vulvovaginal candidiasis. That is the initially you will give fluconazole 150 milligram every 72 hours for 3 doses, followed by maintenance dose 150 milligram weekly for 6 months. Okay, then you also have a topical treatment for recurrent vulvovaginal candidiasis with clotrimazole pessary 500 milligram. It is given for 7 to 14 days. Remember, it is treatment is for 7 to 14 days and the same is to be continued. That is clotrimazole pessary 500 milligram vaginally once per week for next 6 months. So whether it is a oral treatment or topical treatment, you have to treat the patient for 6 months. Okay. And if you have a non-candida albicans species, in that particular case for acute vulvovaginal candidiasis, we will use nystatin pessary, that is 1 lakh units per vagina for 12 to 14 nights. Okay, so this is a nystatin pessary. This particular thing you remember, if they are asking specifically for non-candida albicans species, they may ask you a question: following is a drug of choice for non-candida albicans. So it is a nystatin pessary, 1 lakh unit per vagina for 12 to 14 nights. And in recurrent vulvovaginal candidiasis, again nystatin pessary are used, 1 lakh unit per vagina for 14 nights per month for 6 months. So 2 weeks you have to treat for 6 consecutively for 6 months. Okay, so coming to the recurrent vulvovaginal candidiasis in pregnancy, there is a higher rate of asymptomatic colonization of candida species in pregnant women. Almost 30 to 40% pregnant women may have the asymptomatic colonization, and symptomatic candidiasis is also common. There is a conflicting evidence over the safety of fluconazole and other oral azoles in pregnancy, with 5 case reports of skeletal malformations in infants whose mothers took high doses of fluconazole. So there is a chance of skeletal malformations if the fluconazole or the azole derivatives are used during the pregnancy, especially high dose, that is 400 to 1200 milligram per day for extended period. Taking short courses of lower dose, that is 150 milligram, showed no increased risk of congenital malformation. What does the batch guideline says? Improved cure rates of 90% after 7-day course of clotrimazole 500 milligram pessaries compared with 500 with 50% cure rate following the routine 4-day course. So the treatment you have to give for 7 days minimum. Then in breastfeeding, fluconazole enters breast milk in small doses, and breastfeeding can continue following a single dose of 150 milligram. However, higher and repeated doses should be avoided. So for fluconazole, if it is a single dose in breastfeeding, can be given, but higher dose is to be avoided. So that is what is the specific precaution with the breastfeeding and the fluconazole. Topical treatments are safe and effective, and therefore the treatment of choice in pregnancy and breastfeeding, and that is why topical treatments are preferred. Now we will see the treatment of choice in pregnancy. So if you have a vulvovaginal candidiasis in pregnancy, then acute vulvovaginal candidiasis, you will use clotrimazole pessary 500 milligram per vagina once HS for 7 consecutive nights. So 1 week treatment is required for in pregnancy for acute vulvovaginal candidiasis. In recurrent vulvovaginal candidiasis, again clotrimazole is a pessary is used 500 milligram per vagina for once night for 10 to 14 nights according to the response, and the same is to be continued further during the pregnancy weekly. Okay, so again here you have an induction and the maintenance and the clotrimazole in pregnancy. Remember, the topical treatment with clotrimazole is the preferred agent. Okay, so important points to note are: topical or intravaginal treatments can affect condoms and put women at risk of unwanted pregnancy. Fluconazole and other azoles can react with other medications when given in multiple dose regimens, particularly in relation with association with hypokalemia and prolonged QT interval. So these are the side effects of fluconazole. One is a hypokalemia, and second is a prolongation of QT interval. Okay, so if not responding to the treatment, consider testing for species other than Candida albicans or revisiting the alternative diagnosis. Okay, so that finishes the recurrent vulvovaginal candidiasis.